Hello, everyone, and welcome to our American College of Cardiology, Cardioobstetrics, and Reproductive Health Section Journal Club on catheter-based interventions for the management of valvular heart disease during pregnancy. I'm Malamo Contouris. I'm a cardiologist at the University of Pittsburgh. I am going to give an introduction today to the Journal Club just to get us a little bit oriented. We're going to be discussing this wonderful manuscript, which is a comprehensive and fantastic resource for care of patients with severe valvular disease in pregnancy. We're going to focus on just some key points from the paper today through a case discussion, a review of the manuscript, and a panel question and answer session. Next slide, please. A reminder that if you have any questions, please put them in the chat. We'll be monitoring the chat function during the webinar. We'll also be incorporating your questions into the question and answer session at the very end. And a reminder that our webinar will be posted on acc.org. So if you want to catch anything again there, you'll be able to, because it will be recorded. Next slide, please. I also wanted to invite you to join us on Twitter. We'll be continuing the discussion. We'll be having live tweets by wonderful trainees, Dr. Destamalchi from Temple and Dr. Petrechko from the University of New Mexico. So I've put here some suggested hashtags, both with specific to this journal club and also to the ACC Cardioobstetrics section. New slide. Next slide, please. We have an esteemed group of panelists today that include two of the authors on the manuscript, Drs. El-Kayem and Dr. Mehra. They're going to be joined when we open the panel for a question and answer session with a maternal fetal medicine specialist, Dr. Jayabalan, and advanced imager, Dr. Gonzalez. And without further ado, I think we have maybe a couple more slides, but I'm going to kind of go through those very quickly. Tina, if you want to just advance through the rest of them. I think that is pretty much the end. So I'm going to ask Dr. Panna, who is a third-year cardiology fellow at Vanderbilt, to share her screen with us. She has an interest in cardioobstetrics. She attended the Indiana University for medical school and did internal medicine residency at Massachusetts General Hospital. After her graduation from fellowship, she plans to continue in cardioobstetrics, caring for cardioobstetrics patients at St. Vincent Hospital in Indianapolis. Dr. Panna, take it away, and we're very interested to hear your case presentation.
Perfect. Thank you for having me. So I will go ahead and get started with the case. So we have a 35-year-old female, G2P0101, who presented to our cardio OB clinic at 22 weeks, 4 days gestation with worsening dyspnea on exertion, orthopnea, dizziness, and she actually had 2 episodes of syncope. She worked as a hairdresser and noted that she couldn't even stand to do her work because of how symptomatic she was. She did have a past medical history of a bicuspid aortic valve, although her last echo was in 2009 and it showed mild to moderate aortic stenosis, with a mean gradient of around 19, peak velocity of 3.0 meters per second, and an aortic valve area of 1.7 centimeters squared. From an OB history perspective, she had a prior classical C-section in 2006. That was at 26 weeks gestation due to placenta previa and preterm labor. She's not on any medications and has no known drug allergies. On exam, her blood pressure was 91/52, heart rate was in the 80s. Most notable for she was sitting bolt upright, not able to speak in full sentences due to her respiratory distress, having to take frequent breaks when telling her history. She had a 5 out of 6 crescendo murmur in the right upper sternal border with radiation to the carotids and a diminished S2, and then 1+ pitting edema. Because of how symptomatic she was and her exam findings, we arranged for her to have an echo that day in clinic. And so I'll briefly go through some of the images from her echo. You can see here a parasternal long view, and the most notable thing is that calcified aortic valve with reduced excursion. And then I would say that her LV wall thickness is increased. Hard to get a sense of her EF in this view, but we'll get a better view in subsequent images. This is a parasternal short axis view of her aortic valve, and you can see here the heavy calcification. Kind of difficult to discern which cusps are fused, although on prior echoes it was noted to be right-left fusion. Moving on to her apical view, so you can see here on color Doppler, she definitely has at least mild AI and turbulence across her aortic valve, suggesting some degree of aortic stenosis. Then continuous wave Doppler through the aortic valve was obviously interrogated in multiple different views. Here is where we were able to get the maximal values. She had a Vmax of just under 6 meters per second with a mean gradient of 93 millimeters of mercury. And then pulse wave Doppler through her LVOT, her calculated aortic valve area was just over 0.5 centimeters squared with a dimensionless orifice index of 0.15. The final read on her echo, normal LV size, her EF was noted to be mildly reduced at 45 to 50% with moderate to severely increased wall thickness, normal RV size and function. She had a heavily calcified aortic valve with restricted leaflet motion, but noted to be bicuspid. She had very severe aortic stenosis with a peak velocity of 5.8 and a mean gradient of 94 millimeters of mercury. Her calculated aortic valve area was 0.53. She had mild AI and a mildly dilated ascending aorta at 39 millimeters. So she was admitted directly from clinic to the step down. Her admission labs were notable for a BNP of 622, a troponin of 0.02, and a lactate of 1.2. She was very quickly transferred to the CCU after admission because of an episode of hypotension and pre-syncope while ambulating to the restroom. And kind of simultaneously while this was happening, the TAVR teams and the CT surgery teams were consulted, and MFM and neonatology were also engaged at this point. And ultimately, it was decided that she was going to need an intervention during this pregnancy. It was unlikely that she'd be able to make it through this pregnancy, as she, again, was just 22 weeks gestation. And so given her critical aortic stenosis and her tenuous clinical status, we decided that we were going to need to intervene this pregnancy. So we had a multidisciplinary discussion with the teams that we described before. And there were kind of 3 options that we thought we could potentially pursue in her. The first being a surgical aortic valve replacement. This was thought not to be ideal given her gestational age. She was right around peri-viability, and there was a very high risk of preterm birth at that stage. And the patient really wanted to stay away from this option because she had a prior preterm birth at 26 weeks, and that child had significant medical problems from being very premature. So the next option was a potential balloon valvuloplasty. And ultimately, we thought it wasn't the best option for her, given her mild to moderate AI and her heavy calcification of the aortic valve. And there was also a question about if that would be a durable solution for her. So the last option that we talked about with the teams was urgent TAVR. And so that was the decision that was made. A day after admission, she underwent TAVR. ECMO was on standby. The decision was made with the neonatology team that we were not going to pursue fetal monitoring during the case because of that peri-viability. And a TE was going to be used for procedural guidance, and she was intubated given the concern for slowed gastric emptying during pregnancy and concern for aspiration. So she underwent TAVR. Her initial mean gradient was 124 millimeters of mercury. When they were trying to cross the aortic valve, they noted heavy calcification, and it was difficult. So they switched to a transseptal approach, and the thought was that they would hopefully save her some radiation by not having to continuously try to cross that aortic valve. Her post-TAVR mean gradient was 8 millimeters of mercury. She had no conduction abnormalities after the case and no aortic insufficiency either. She did have her total radiation dose from the case was 548 milligray, and she had 48 minutes of fluoro time. And this is her post-TAVR echo. Her EF looked much better, more like 60 to 65%. You can see the TAVR valve that's in position. And function of that aortic valve was was excellent. She had a mean gradient across that valve of 14 and a peak velocity of 2.5. So after her TAVR, her symptoms drastically improved. She's noted multiple times when we saw her in clinic and in the hospital after the case that she didn't realize how bad she felt. She just thought this was normal pregnancy. And her third trimester echo showed a stable ascending aortic dilation and a normal functioning TAVR valve. She ultimately underwent C-section at 37 weeks due to obstetrical indications, not cardiac indications. And that was because of her prior classical C-section and wanting to avoid her going into labor. And then her postpartum course was relatively uncomplicated. She did have some mild lower extremity edema, and so she was treated with 3 days of PO Lasix, but she was discharged, and her baby are doing very well. I'll go ahead and stop sharing.
Thank you, Dr. Panna. That was a wonderful case. I think it's going to set the stage really nicely for a robust discussion today and really nice outcome for your patient during her pregnancy. I'm going to have Dr. El-Kayem and Dr. Mera share their screen, and while they do that, I'm going to give a brief introduction for them. Dr. El-Kayem is really a pioneer in cardioobstetrics. He's a professor of medicine and professor of obstetrics and gynecology at the University of Southern California. He's established clinical and academic services of maternal cardiology at the University of Southern California back in 1981 and has been the director since then. He's published numerous really landmark articles on pregnancy and heart disease, including valvular heart disease, MI, and peripartum cardiomyopathy. Dr. Mera is a professor of medicine at the University of Southern California as well. He is director of the cardiac catheterization lab there and director of the Interventional Cardiology Fellowship Program. They are both authors on the manuscript that we're discussing today. And without further ado, I will pass it over to them.
Okay, great. Yeah, really fascinating case. One thing for sure, this patient needed an intervention during pregnancy. So I'm going to focus on the aortic stenosis. This is a paper that was published in JACC Advances. For those of you who are not familiar with JACC Advances, let's see, now is the youngest member of the JACC family. Some of the focuses of this journal are cardioobstetrics. Candice Silversides is the editor-in-chief. I'm on the editorial board, so we're really trying to create a stage for excellent papers dealing with cardioobstetrics. Now, with the emergence of really TAVR, and now we see a number of cases of TAVR during pregnancy, the feeling of the editorial board was that we need to have a very detailed paper on catheter-based interventions in pregnancy. So this is a very large paper, 10,000 words, so we're going to just take a portion of it, which is relevant to the discussion. So as a way of introduction, pregnancy in women with valvular heart disease, both congenital or acquired, can pose a challenge to clinicians and their patients. The marked hemodynamic changes, including an increase in blood volume, increase in heart rate, and stroke volume, can lead to clinical deterioration and maternal and fetal morbidity and even mortality. Most women can be managed medically, but when medical therapy is ineffective, mechanical interventions are needed to prevent maternal and fetal complication. So these are the potential interventions. Obviously, the patient presents early, then termination of pregnancy has to be discussed. My experience has been that almost uniformly, women do not accept this option. So surgical aortic valve replacement is still the gold standard, and we'll talk about the downside of that. Aortic balloon valvuloplasty was mentioned here, and the TAVR in pregnancy. This is the latest paper just published in the European Heart Journal, looking at the outcome of cardiac surgery done during pregnancy. And you can see both maternal mortality as well as fetal mortality fetal mortality has been known to be increased when a woman has surgery during pregnancy. But it is interesting that even recently we have not found a way to decrease fetal mortality. And the mortality on the average was 26%. Didn't make a difference what trimester. It seems like in the first trimester is somewhat higher. I think surprisingly, maternal mortality was 7.3%, mostly because of the fact that these patients were really sick. So the high likelihood of fetal loss is an issue. The other issue is the early implantation of a prosthetic heart valve. Both bioprosthetic as well as mechanical prosthetic valve have disadvantages if they're being introduced too early. The bioprosthetic valve because of the durability issue, and the mechanical prosthetic valve because of the anticoagulation that makes things a little bit more complicated. Now, this is really the team of physicians that we feel need to be involved in the care of patients with complicated valvular disease. Obviously, a cardiologist with experience in the management of pregnant women, a maternal fetal medicine individual, as a high-risk obstetrician with experience in the management of cardiac patients. Now, a cardiologist with experience of the management of valvular disease. Now, echocardiogram has been critical in the decision-making process, and because of that, it is really important to involve a cardiologist with skills and knowledge of what we call advanced echocardiography. We need somebody that will guide us in terms of the radiation, a structural cardiologist in case that an intervention is indicated, a surgeon in case that surgery is indicated. The obstetrical anesthesiologist is part of the team, but in these cases, oftentimes we need the help of a cardiac anesthesiologist. A neonatologist, a lot of these cases will present early. The decision in terms of early delivery and so on and so forth, it's important to have somebody that can guide us in the decision-making process in this regard. Now, the management of a patient with aortic stenosis ideally will start before the pregnancy. It involves a careful cardiac evaluation. The history is critical because the patient who has had a history of complication before the pregnancy is almost guaranteed to have the same complications and more during the pregnancy. The physical exam is very important. You see on the right what you can actually get by listening to the patient. It does help you sometimes when the echocardiogram can be questionable. So the echo is the gold standard, but those of you who are dealing with the valvular disease know that echo has its own limitation, and because of that, in a questionable patient, the patient was just presented, there was no question that the patient needed an intervention. But sometimes these patients, the indication is not as clear-cut. So exercise testing is extremely important. Remember that these women are usually sedentary, and a decrease in exercise tolerance can be secondary to deconditioning. So cardiopulmonary exercise tests to really have an understanding about the capacity of the patient to perform exercise is extremely important. The BNP has been important, and you saw that the BNP was elevated in the patient presented. So not only for the diagnosis and assessment of severity, but also follow-up of this patient throughout pregnancy. In a lot of these patients, you're not going to get the answer without hemodynamic evaluation, which we recommend before you make a major decision. And doing an intervention, doing a termination, deciding on a C-section, all of these are major decisions that need to be supported by as much evidence as you can. Abnormal exercise testing. Everybody's talking about you have to do exercise testing. So what are the criteria for abnormal exercise testing? Symptoms, reduced work load, less than 5 minutes. And what does it mean? The patient is not able to perform 6 minutes on the modified Bruce, maximum oxygen consumption of 17 or less, fall in systolic blood pressure of at least 20 millimeter of mercury, malignant arrhythmias, and an increase in pulmonary artery pressure to more than 60 millimeter of mercury. So I think the message here that the assessment has to be multidimensional before we make a major decision. Recommendation for interventions before pregnancy. The European Society of Cardiology says the patient is either symptomatic or has LV dysfunction, but also the patients who are not symptomatic and have normal left ventricular function, they say if the gradient is actually high enough, over 60, then you should consider an intervention. The American College of Cardiology is even more aggressive in terms of intervention before pregnancy. They draw the line at 40 millimeter of mercury as a mean gradient, and basically say that you do this in anticipation for worsening. That means an introduction of a concept which is a prophylactic surgery before the pregnancy. So this is coming from the ROPAC registry. I see it in a very small letters here on my screen, but in any case, you can see that 60 women who were asymptomatic with moderate to severe aortic stenosis, there was 0 mortality, maternal mortality, and 0 fetal mortality. In terms of the complication, the most common complications was heart failure in 8% of the patients. But if you see the management of this patient, then all this patient, including the patients that were symptomatic, could be managed medically. And there was only one intervention in a very, very sick patients over there. So I think the message for those of you who have been now getting into the field that aortic stenosis in most cases is well tolerated, and rushing into doing an intervention really has to be supported by a lot of information. So the valvuloplasty, so because of the risk of surgery during pregnancy, valvuloplasty is considered to be the first-line option in pregnancy if suitable valve morphology is present. The American College of Cardiology guidelines say the patient has to be very symptomatic to consider the procedure. Now, but for the clinician, I think it's important to remember that in pregnancy, you cannot rely on symptoms alone. Symptoms can be deceiving. On the right, you see normal pregnant women. In the gray area, at least 20 to 40% as pregnancy progresses will develop symptoms which mimic the symptoms of heart failure. And in the small letters, you see that we're talking about really a very mild form of exercise that is associated with symptoms. So how do you decide on the difference between hemodynamic deterioration versus just the usual presentation of pregnancy? I mentioned the BNP, PA pressure by echo. There have been a number of studies, by the way, showing that in pregnancy, the PA pressure can be overestimated by echo, and we see it all the time. And because of that, again, a major decision, as much information as possible. These are the patients published in the literature. This is the table from the paper showing the patient who had valvuloplasty. I'll summarize it for you. 70% had congenital and 30% rheumatic. The pregnancy week ranged between 13 and 36. The gradient was very high before the procedure. The gradient improved significantly after the procedure. Post-procedure aortic regurgitation in about a third of the patients. So that's the concern of a valvuloplasty. It was moderate and it was well tolerated in all patients, and all patients were able to complete the pregnancy. Maternal complication, there was a seizure in one patient during the inflation and tachycardia in another, and there were no fetal complications. In general, in this patient population who have relatively pliable valve, and the degree of calcification is usually not very high, a balloon valvuloplasty is definitely a consideration. So the TAVR. This is the information in the literature. The first one on the left is a native aortic valve, and the rest of the patients are valve-in valve. Let me just summarize it for you, the valve-in valve. 6 reported patients, the presentation between 5 and 13 years after the surgical valve replacement. TAVR was performed between 12 and 22-week gestation. Balloon expandable valve was used in most of the patients and self-expandable in only one. The transvalvular mean gradient really improved significantly. There's no information about long-term follow-up in this patient population, so we don't really know the durability of this valve. This is one case. I'm not going to go into details because I want to leave time for discussion that had the valve-in valve. This is the only case published in the literature of TAVR in a native valve. This is a young woman who was completely asymptomatic before the delivery, before pregnancy. She presented with symptoms of dizziness, dyspnea on exertion, and chest discomfort. The echocardiogram showed a mean gradient of 38, and the valve error was 1. The patient was exercised as one should do, and she was able to perform 8 to 9 METs. She had a successful TAVR. She developed a left bundle branch block. Temporary pacemaker was used for a while. She left the hospital on day 5, persistent left bundle branch block, and she was able to complete her pregnancy. So this study definitely shows, and the study that we have seen, that we can perform TAVR during pregnancy. The more important question that everybody has to ask herself or himself, does the patient need the procedure? Does the patient need the procedure? And then we definitely have the option of a TAVR or valvuloplasty. We felt that it was really very important to educate physicians about the potential challenges doing a TAVR during pregnancy in a patient with a bicuspid valve. This is a very detailed table that we had in the paper. I'm going to give the microphone to Dr. Mera now, that was going to take us through some of these issues that I think every physician who considers doing a TAVR need to be familiar with.
Yes, so in next around 10 minutes, I will try to go quickly. And I will just go over some of the limitations of, or some of the cautions one needs to have it when considering TAVR in pregnancy. I mean, everybody knows the TAVR initial concept was made almost 34 years ago, and I first got an approval in 2002. Sorry, I got a first human implantation in 2002 and approval in 2007 in EU, as well as a FDA approval in 2012. And majority of these cases have been done in a degenerative calcific aortic stenosis in the elderly, in the high risk or very high risk, and lately have been done mostly in moderate risk, and low risk is still not approved. There are 2 types of valves which we consider. The one is the self-expanding valve, which is mostly the SAPIEN valve, and the series of that now is the SAPIEN 3 or SAPIEN Ultra. And there is one valve which is available outside of the US, is called a MyValve. In the self-expanding valves, there are 2 different types. One which is called an annular plane valve, or which is implanted at the site of the aortic annulus, which is the portico valve, and the Evolute, which is a series, which is the Evolute Pro now, with our Pro Plus, which is a supraannular valve. The mechanically expanded valve, which is the Lotus valve, have been essentially discontinued because of high risk of pacemakers. And the For the valve which is used for a aortic regurgitation, the Jena valve, still under development. So mostly we are trying to do either the self-expanding valve, which is the Medtronic Evolut valve, or the Sapien valve. And etiology in the patients who are younger, like the pregnant patients, is mostly in relation to the bicuspid aortic valve or unicuspid aortic valve. And at least in the developing countries, and we don't see much of the rheumatic heart disease, but outside the US, in developing countries, you may see rheumatic aortic stenosis in the pregnant patients. So, but mostly it will be either a bicuspid aortic valve or a pregnancy. The overall experience of, as you heard, that with Dr. Al-Qayyem, that's very limited. I'm sure there are a number of TAVR procedures done around the world in pregnancy, but at least the reported experience has been in 6 cases in valve and 1 case in native valve, and the 1 case which was presented is the 2nd case in the native valve. There is one earliest case, actually not really published in literature, but at least you see it online, is from the Canada, which they thought that they did a first, TAVR valve in a native valve. I'm not going to go over this particular slide because you already saw that. So I'll just skip it for the sake of discussions. But TAVR can be done in pregnancy with a very low maternal or mortality as well as fetal mortality. Obviously, the advantages, as mentioned earlier, the advantage is avoidance of surgery, because surgery is associated with a high risk of maternal and fetal mortality, especially if the maternal surgery is done in urgent or emergent conditions. The mortalities are high even for mother. So what are the potential indications of TAVR in pregnancy? One is patients with severe aortic stenosis who present with class 3 or 4 heart failure, who is unresponsive to medical therapy and is not suitable for balloon valvuloplasty, namely because of the aortic regurgitation or severe aortic valve calcification. Or you attempt aortic balloon valvuloplasty and they end up developing a severe acute AR. That will be the indication for you to do the TAVR. And the patients who have degenerative bioprosthesis who present with symptomatic severe AS or AR, there will be another consideration for valve-in-valve TAVR. But one needs to really keep in mind that the limitations are there, and there are some considerations one need to give before we jump into doing a TAVR, especially in what we call a native valve. The bicuspid aortic valve has a variable anatomy, and usually in younger patients there is a lack of calcification. The sizing of the valve, whether one does it with a TE versus CT, the TE, generally the size is considered on a smaller size than the valve. The CT provides an accurate assessment of the valve as well as the height of the coronaries, but one needs to limit the CT to the chest and not really radiate the baby, as well as by avoiding the abdominal CT or the peripheral vascular assessment. The future coronary access, because these patients are not immune to developing future, coronary arterial disease, so that should be under consideration. Risk of coronary occlusion and the aortic wall injury, permanent pacemakers need, and the long-term consequences of permanent pacing. And importantly, we have very limited experience in long-term durability in younger patients like this. We know from a surgical literature of a bioprosthetic aortic valve or bioprosthetic valves in younger patients, the early degeneration. So it's an unpredictable duration what you will be looking at after doing a TAVR. And in those cases where they need again now the valve, because of valve degeneration, you need a second valve, then a valve-in-valve TAVR, has issues in patient prosthetic mismatch. And a SAVR for a TAVR has its own limitations in terms of complexity of the surgery. The anatomy of the bicuspid aortic valve, as you can see, the Seaver classification, which defines in the number of raphe. If your raphe is no raphe or a 1 raphe, then one can consider doing a TAVR in a native bicuspid aortic valve. But the Seaver class 2 or the type 2, where you have a 2 raphe with a very eccentric opening of the valve, is generally considered to be a surgical indication and not a TAVR. So if you see a Seaver type 2 with 2 raphe, that's not a TAVR valve. Then there is a consideration of something on the anatomy of as to where the narrowest complex in this AV valve complex, the narrowest portion or where the stenosis is existent. There's something called a codominant situation where we have a virtual raphe ring as well as the basal ring at the annular plane are the same size, or you could have a annular plane which is narrowed, or you could have a narrowing at the tip of the valve, which is basically the virtual raphe ring. So if you size the valve in relation to just the tip of the valve, then you will be undersized at the annular level. If you size the valve in an annular plane, that you have essentially an undersized valve. So complexity of this anatomy is best determined by the CT, but obviously the CT leads to, or at least associated with the risk of radiation injury to the fetus and the mother, both. And one needs to consider, and probably in those cases, just limit the CT to the chest. Undersizing of the valve will lead to embolization or paravalvular leak. Oversizing is going to lead to annular injury, but more importantly, permanent pacemaker need, increased risk of permanent pacemaker need. The lack of calcification, obviously the holding force of the calcification in the degenerative calcific aortic stenosis is where the implantation is done. In a lack of calcification is an issue, and in order to avoid either the embolization or the permanent pacemaker, one either oversizes or undersizes the valve. And there are some discussions as the case which is published, the only case published in a native valve where there was no calcifications. They suggested for doing a slight oversizing and using a self-expanding valve because they didn't use the CT sizing, so they used the TE guidance. And because of the repositioning ability also of the self-expanding valve, then a proper sizing, if it's not done, one can essentially retrieve the valve. So self-expanding valve with slight oversizing to hold the valve, but in a ventricular implantation is suggested, is even in a rheumatic aortic stenosis, but this will result in an increased need for permanent pacemakers. And if you undersize the valve, then it will obviously lead to paravalvular leak or embolization, potentially. The permanent pacemaker is higher rate in a self-expanding valve than the balloon expandable valve. And that is because of the conduction system which traverses through the membranous septum. So if you implant the valve deep, especially more than 3 millimeter in difference in relation to the non-coronary cusp, then the risk of injury to the conduction system is high. In a long term, there are device-related complications, namely tricuspid valve injury with tricuspid regurgitation, may need for future tricuspid valve surgery. Because of persistent pacemaker need, you may have increased risk of heart failure hospitalization and even a mortality in long term. Future coronary access. If you use a balloon expandable valve, then even in those cases, around 5% of the patients may have a difficulty in accessing the coronaries. But the self-expanding valve in the present situation, even with the so-called a cusp overduct technique, which is a technique to avoid and pacemaker implantation, as well as improve the access to the coronaries, still in those circumstances, 1/3 of the patients will have difficulty accessing the coronaries. So portico valve, the accurate neo valve, the new valve has a better accessibility. So some of the newer self-expanding valve will be better in those circumstances, but one needs to consider the potential for future coronary access. The future need for valve replacement, repeal intervention is inevitable because the younger age of the patient and the longevity will outlive the bioprosthesis of the TAVR. TAVR in TAVR is a prosthetic. One needs to consider the potential patient prosthetic mismatch. The SAVR in TAVR is a difficult surgery with risk of injury to the aortic valve, aortic wall, annulus, as well as mitral valve injury. And this is an explant TAVR registry, which is a degenerative calcific aortic stenosis. And as you can see, even in-hospital mortality in these patients who undergo either elective or urgent surgery is around 5 to 10%, but a one-year mortality is almost 30%. So one needs to consider, and that's a difficult surgery. So in this particular registry, the need for concomitant surgery, apart from the aortic valve replacement, was around 50%, and that involved mitral valve surgery in 32%, ascending aortic root replacement and coronary reimplantation in 10%, and some form of a root operation in around 18%. So there is a significant injury to the surrounding tissue, especially with the self-expanding valve, where the aortic wall injury will be higher. But even with self-expanding valve, you will have a mitral valve injury, which may need surgery in the future if you do a SAVR in TAVR. So in conclusion, the ease of TAVR over surgery during pregnancy should not lower your threshold for indications. The decisions of TAVR should not be based on increasing gradients alone. And if needed, one needs to understand the symptoms with low threshold to do the hemodynamic assessment prior to considering TAVR. Thank you.
Great.
Fantastic presentation. Thank you so much for that overview of just actually a brief portion of the paper, because we really just honed in sort of on aortic valve disease and essentially TAVR, which I really appreciate the level of detail that you presented on. I think I would like to open the panel now to also include Dr. Holly Gonzalez, who's a cardiac imager at Atrium Health in Charlotte, North Carolina. She has a focus on interventional and structural imaging. And then to also include Dr. Arun Jayabalan, who's a maternal fetal medicine specialist. She's an associate professor in the Department of Obstetrics and Gynecology at the University of Pittsburgh. She's also director of the Division of Maternal Fetal Medicine there. And she has a longstanding research portfolio in cardiobstetrics and hypertensive disorders of pregnancy. I want to take us back, actually, and Dr. Panna, maybe you can sort of weigh in on your case and sort of what was done with the case from an imaging perspective. And Dr. Panna, if you could maybe talk about prior to this person sort of presenting with her syncope, if she had had any diagnostic imaging and what that looked like up to that point. And then maybe for Dr. Gonzalez to also weigh in on sort of what do you expect to see from an imaging perspective, changes in valve gradients, if we kind of stick to talking about the aortic valve, what's the normal change expected in pregnancy, and how do you know when something is, progressing?
Sure. So from this patient's perspective, she actually had her last echo in 2009, and then she was lost to follow-up. In 2009, I think her mean gradient was around 19, velocity around 3.0. And then she was just lost to follow-up at that point. She, was in her early 20s and knew that she was going to have valve problems later on, but did not seek cardiology consultation prior to this pregnancy, and then ultimately took her a lot of hoops to jump through to end up seeing a cardiologist during this pregnancy. So she presented really decompensated by the time she was able to find us. But obviously would have loved if she would have had an echo prior to this pregnancy and earlier on in this pregnancy as well. Could have changed the outcome, and definitely our choice of intervention if we had known about her severe aortic stenosis prior to pregnancy.
Awesome. Well, thanks, Lindsay. So yeah, as kind of discussed already, pregnancy has some effects on valve gradients, particularly in aortic stenosis and stenotic valve lesions. So because our blood volume increases, because our heart rate increases, that increases our transvalvular flow rate through the aortic valve. And so that will increase the flow-dependent parameters like your gradients and your peak velocities. It's less likely to affect the flow-independent parameters like your aortic valve area or your dimensionless valve index. So those can be helpful to kind of parse that out when you have the increased flow rates during pregnancy. And again, because of that increased flow rates and the increased gradients and whatnot during pregnancy, that's why stenotic lesions are less well tolerated in pregnancy. So mitral stenosis, aortic stenosis, less well tolerated than some of the regurgitant lesions that we can see. And so, you know, then like there can be a challenge. Like what if there's discordant aortic stenosis, you know, because our gradients are high, but our valve area is low, if they have symptoms, but as discussed, the symptoms of heart failure are often the symptoms of pregnancy. So very difficult to figure that out. And so, you know, normally in a non-pregnant patient, we can rely a lot on CT. We can look at CT aortic valve area. We can look at CT calcium scores. But this is a totally different population, and we really want to try to limit the radiation if we don't absolutely need it for something like planning a TAVR, for example. So we would probably try to avoid that. And then I think that really opens the door in these discordant cases where you're really trying to figure out management for invasive gradients. And so invasive hemodynamics, which are our gold standard, I think are still really helpful. There is a little fluoroscopy and there is some invasiveness to that procedure, but generally pretty well tolerated and can help answer questions when you're on the fence.
Awesome. While we're sort of, you know, talking about being on the fence, you know, I think Drs. El-Kayem and Dr. Mehra sort of talked a little bit about this in terms of when do we pull the trigger on intervening in pregnancy. And I was hoping maybe also Dr. Jayabalan could weigh in from the, you know, sort of delivery perspective. You know, in the case that Dr. Panna presented, this person was sort of peri-viable, just sort of pre-viable. When do you take that into consideration, delivery versus intervention, and how do you kind of weigh that?
Not an easy answer, for sure. You know, almost everything we do in pregnancy is so gestational age dependent, and I think any decision would definitely be very multidisciplinary. But in terms of pregnancy outcomes, certainly when we get to the latter part of the third trimester, 32 to 34 weeks, pregnancy outcomes, fetal neonatal outcomes are generally very good, with mostly some short-term issues and a shorter NICU stay. So when you get to those gestational ages, I think really weighing delivery versus a major procedure, I think is weighted more towards delivery. I think that some of the earlier gestational ages are a little bit harder to figure out exactly where that cut point is for delivery. And I think that's where bringing in other members of the multidisciplinary team are going to be important, including neonatology, and thinking about other interventions if delivery is you know, going to be likely, like betamethasone for fetal maturity, magnesium sulfate for severely premature delivery to reduce the risk of cerebral palsy and things like that. Not a precise answer, but really kind of balancing, bringing some of the patient's, you know, thoughts and desires into the mix as well.
Maybe I'll let Drs. Mehra and El-Kayem also weigh in on that one.
Yeah, you know, it's interesting that we say that, you know, we're doing very well with premature babies. On the other hand, we're trying to basically get to 39 weeks, right? Yeah. So I think that, you know, the multidisciplinary meeting is very important. My experience has been that the obstetricians are very anxious to deliver the baby. And I always tell them, you know, I mean, if you're really concerned about the baby, about the mother from the cardiac standpoint, then the cardiologist should make the decision. In many of these patients, we can stabilize the patient and allow them to basically complete the pregnancy. You know, my friend and former student, Afshan Hamid, says that, you know, cardiac patients, they like to deliver at 37 weeks, even if it's really no indication for that. And every time that I tell her that, no, we can continue, she said, oh, you have more experience. You have more experience. So, what I'm trying to say is that you're right. It's a balance. I mean, a patient that was presented, this patient was very, very sick. She was not only very symptomatic, but the symptoms were based on hemodynamics, right? She had very high gradient. A patient like this really has a life-threatening condition. So here you have to do something, either deliver, if the patient can be delivered, or do an intervention. So you're right. I mean, it's always a difficult decision, but what I'm trying to say is that today, this is aortic stenosis. We have patients with very severe LV dysfunction that we're delivering now, but we have now the means to stabilize the patient. And if we can stabilize the patient, a patient with aortic stenosis with a valve AF1 is very manageable, manageable. It may be scary, and the patient may tell you that they have symptoms, so you have to sort of read between the lines, what is really hemodynamic deterioration and what are the symptoms that we see in many of our patients, right? At the end of the pregnancy, they're not able to lie flat, they're uncomfortable, and so on and so forth. So now I showed a slide. I didn't have time to go over the details. You saw that the rate of C-section in the asymptomatic patient in the ROPAC registry was 50%, 50%. And on the average, there were 18% of the patients who had prematurity less than 37 weeks, and I think a lot of it is iatrogenic. A lot of it is decision that we make, that we want to deliver the babies early and we want to do a C-section. Both are in many cases really unnecessary. And especially I'm really offended by a very low threshold for C-section in this patient population.
And Dr. Panna, maybe you could weigh in too in this patient's case. Why the decision for TAVR versus other interventions? I know you had one slide but I just wanted to make sure that we kind of talk about that. Why not balloon valvuloplasty in her case?
Yeah. So again, I think most important is to have a lot of people in the room weighing every different option. And we had talked to CT surgery, our structural colleagues, MFM, neonatology. Ultimately, why we decided against, I think it was pretty clear SAVR was not a good option in her, just with the really high rate of maternal mortality and also fetal risks. And then the balloon valvuloplasty, her valve was so heavily calcified, and she had mild, was on the final read of her echo, but maybe mild to moderate AI, and just felt that the degree of calcification plus the aortic regurgitation, that balloon valvuloplasty wasn't optimal for her. And that's why we ended up going forward with TAVR.
So, without, obviously, you cannot, without seeing the patient and without having all the information, it's difficult I don't want to really criticize, or I don't want to have an opinion without really knowing the patient very well. But I would like Dr. Mera to make a comment about, what level of calcification, what level or degree of aortic regurgitation for him will be not a very good idea to do a valvuloplasty.
So at least from the echocardiogram, what you showed to me looked like that on a short axis view, it was mostly the non-coronary cusp which was calcified. I didn't see the calcification on the, the fused right and left coronary cusp. So I don't know the CT did show any calcification in the right or the left coronary cusp. Mostly what I saw was the non-coronary cusp, and that too mostly at the tip area. I didn't see at the base area of the coronary cusp. So I'm not sure, whatever the calcification will be. Obviously, the valve is definitely very stenotic because I'm sure something happened that you were not able to cross the valve on a retrograde way, and that's why you went transvenous. But then the implantation, what I see, at least on the picture, is a retrograde implantation. So I didn't know exactly as to how they did it in terms of, redoing it. And if it is such a heavily calcified valve, generally in a bicuspid valve, even in older age group patients, we will do a balloon valvuloplasty to begin with. So one can argue and say, okay, you do a balloon valvuloplasty. If you get a moderate result, which you are expecting a moderate result, would you bring a gradient down and pressures down up to the point that you can carry this throughout the pregnancy? So I don't know. I'm just kind of asking, but one could have done the balloon valvuloplasty and you are ready with the tower anyway in case you need it, just like you were ready with the ECMO if you need it. I'm not sure ECMO was needed, but you were ready with it, and one can do that. So I don't know how they did it, transvenous.
I see Dr. Gonzalez also nodding her head. Maybe from an imaging perspective, you could give a tidbit too.
Yeah, I mean, I agree. I happen to have seen the CT scan of this patient where actually the raphe is highly calcified from base to tip, in addition to the non-coronary. So lots of calcium on that valve. And yeah, I think, if you have the luxury of having a CT scan, which I would recommend, as long as you can do that, and you can minimize your radiation with CT scan by doing gated CT in only the systolic phase, and so very low radiation for that. If you have that luxury, then you have the option of balloon valvuloplasty and a bailout TAVR if needed. So either way, I think it's nice to have the options, and CT really helps guide that.
Can I pose a question to Dr. Jayabalan also about fetal monitoring during these kind of procedures? Sort of what do you typically recommend? Is there a gestational age when you might think it's a little less essential, or how do we coordinate that with our obstetricians and maternal fetal medicine colleagues?
Well, I think a lot of it, again, is based on gestational age. Obviously, if it's pre-viable, then we usually do heart tones before and after the procedure with kind of reminding our anesthesia and cardiology colleagues about the leftward tilt and maintaining blood pressure. Beyond viability, what we generally will do is a non-stress test pre-procedure, and then again, close monitoring of blood pressure, et cetera, and a non-stress test post-procedure. There are folks who do continuous intraoperative monitoring. I think it's really important to know exactly what you're going to do with that information if you are going to do the monitoring. And so I think that our leaning has been towards pre and post-operative monitoring. But I know that that's not consistent at all places.
Wonderful. Thank you for that. I do recognize that we are just beyond the hour, so I have one sort of final question that I wanted everybody to weigh on, and this is sort of a broad one, and you each have touched on the importance of the multidisciplinary team. I want to just highlight for the people tuning in sort of what does that look like at each of your institutions, and in the situation of a severe valvular disease case in pregnancy, how do you convene the teams together? How do you bring together the multidisciplinary team in the discussions, just to get a snapshot of what it can look like at different places? Maybe Dr. Jayabalan, since you're unmuted, I'll have you start.
Great. So at our institution, and Malamo, you're here as well. So usually the key players are maternal fetal medicine and cardiology as kind of the key folks in the initial communication. And then we bring in many other members of the extended team, including neonatology, OB anesthesia, OB cardiac anesthesia, CT surgeons, appropriate imaging, et cetera. So again, I think that at our institution, we kind of have MFM and cardiology at the core, and then pull in all the other services. We have an interesting setup because we we're at a women's hospital, McGee Women's Hospital, and so some of our services like ECMO and CT surgery are at a separate hospital, not too far away, but a separate hospital. So if we we have to also make some decisions about location of delivery and in terms of coordinating all those services.
And we do a once a month multidisciplinary team meeting where we talk about all of our high risk patients too. So that.
Yeah, and we all have each other's cell phones, so we can text pretty quickly, and then jump on a Teams call or and get folks talking directly. So virtual has helped a lot with that.
Dr. Al-Qayyum, I see you unmuted. Do you want to weigh in?
Yeah, so I just want, as I indicated before, we all cardiologists, but we all have different specialties and experience. Now, a case like this really requires a cardiologist with experience in the management of complex valvular disease. So, some of us are very good at dealing with the coronaries, and some of us are very good at dealing with valvular disease and heart failure. So you really have to bring in, it's not enough to have a cardiologist or maternal fetal medicine representative. It's really, you want to bring the people with the most experience for this particular specific case, because you understand the interventional structural cardiologists are very likely to have a very low threshold of doing a TAVR in a case like this. So it really requires somebody who has experience in the management of pregnant women with cardiac problems. You understand, knowing, how can we help patients. I'm not talking about this patient who was very sick, but now our limitation and also capabilities in managing a cardiac patient during pregnancy.
And then Dr. Gonzalez and Dr. Panna, I know you were at one point at the same institution, so maybe you want to give that perspective and maybe at the institution you're at now too.
Yeah, sure. And I'll let Lindsay chime in because I know she was involved with this case too. But I think at both institutions and many places that do high volume valve procedures, both transcatheter and surgical, there is at least a once a week valve meeting that's multidisciplinary. So you get many of the people on that diagram that you guys showed, including imagers, structural, general cardiologists, ancillary staff, anesthesiologists. You get many of the people already in the room once a week. And then we invite in cardio OB and OB and MFM. And so we're able to kind of have a very easy planned multidisciplinary discussion where we go through things in a very systematic fashion already. And so I think that works out really well. And then similarly, we've been invited to the MFM meetings too, and that's also gone well.
Dr. Panna, anything to add?
Yeah, I think obviously if we have time, discussing them at our monthly meeting is great. This patient in particular, I think, was admitted on a Friday afternoon at 4 p.m. and then had her TAVR on Sunday morning or Sunday afternoon, like the week before Christmas. And so obviously we didn't have a big meeting between then, but I think just obviously echoing, like having everyone's phone numbers and calling people and having discussions outside, in the hallway, outside the patient's room, getting everyone on board, and also documenting in our notes, like our plan and our thought process, I think is so important.
Wonderful.
Just like another quick aside is that the revelation of kind of having advanced structural teams and cardio OB, like having those teams in place, I think really helps facilitate these things. So we already know each other. We know each other's cell phones. Like we can really facilitate this quickly and have meetings if needed. And so I really just have loved that.
Yeah, I think having the ability to have the fast, direct communication with the key players is really important. So really wonderful to have you all join us. I appreciate all of your expertise and input in the discussion. I know we are a couple minutes over, so I just want to conclude and thank you all. And if there's anybody wants to take a look at this afterwards, it'll be on acc.org, the recording. So have a good evening.
Thank you. Thank you.